This is QD video brought to you by RheumNow.Live. For rheumatologists, when the going gets tough, the rheumatologists go to RheumNow.Live in Fort Worth on March 22, 23, 24, coming up in a few months. Check it out, RheumNow.Live. So today's case, a 33-year-old Hispanic gal. I'm not seen her in a year because she didn't want to come back because she had no insurance. I told her, come see me. She needs to be seen. She's been taking tocilizumab. She's a rheumatoid arthritis patient, chronic symmetric polyarthritis, wrist, elbow, knees, fingers with swelling, AM stiffness, positive rheumatoid factor, previously treated with methotrexate, Cimzia during one of her last pregnancies, and now she's on Actemra and doing well for the last 2 years on tocilizumab, subcutaneous injection given every other week. She's done fine. In the last year, she's not seen anyone, not had any labs. She had enough drug to last her a year. Now she's back, and she's got 2 requests. One, can I refill her Actemra? She's on a patient assistance program, but she just got insurance, so maybe her insurance will pay for it. And 2, she's pregnant. No, she's not pregnant. She wants to get pregnant. And the question is, what am I going to do about that? And what's my advice to her? So her proposal to me was, I want to get pregnant. What can I do? Do I have to stop? Do I have to go back on that other medicine? Do I have to be on no medicine? And we went through this once before with her, but we're going to go through it again. I think the first teaching point here is that if you have women of childbearing potential, almost every visit should clearly spell out what their intentions are for future pregnancy. If they're on birth control or they're otherwise unable to conceive, well, then you don't have to have this question. But all too frequently, we don't discuss it, and we should. What are your intentions as far as future pregnancy? I don't want any more pregnancies, doc. Well, then you can advise them on what the safe forms of contraception may be. If you don't know that information, the ACR has a reproductive health guidelines group that actually met all last year. I was a part of it, and it's going to be a great publications coming up in the next few months. It's going to be a 3-parter, and it's going to give guidelines for management of patients with rheumatic disease with regard to pregnancy, breastfeeding, lactation, and other reproductive health issues, including contraception. Look for that publication. It is going to be dense with useful information, and I think it should be actually a course taught by the people who are running that, and that includes Lisa Sammartino from Hospital for Special Surgery is leading the effort for the ACR. So what did I do with this patient? I told her, yes, you can get pregnant. No, you don't have to change medicine. You're on Actemra, you're doing well. Number 1 rule of getting pregnant is to be a healthy mom so you can make a healthy baby. And that can be accomplished on no medicine if the patient's in remission. It can be accomplished with a DBARD, and safe DBARDs that you can get pregnant on include hydroxychloroquine and sulfasalazine and gold and not methotrexate, not leflunomide, even cyclosporin and whatnot. The most dangerous drug is not methotrexate and not leflunomide, but is in fact mycophenolate. Mycophenolate is a clear-cut teratogen, way more than methotrexate or leflunomide. Do not get pregnant, planned pregnancy on mycophenolate. You can get pregnant on a TNF inhibitor. I mean, there's a ton of data regarding that, but there are other, and of course, you know, that used to be a Class B pregnancy risk, and some of the other biologics are Class C pregnancy risk, like prednisone. But prednisone is the most dangerous drug we use. Peter Merkel said it, right? And I tweeted it, incredibly popular tweet. Prednisone is the most wonderful drug we have and the most dangerous drug we have. Trying to get pregnant with prednisone is foolish and should not be done. This lady's doing great on Actemra. There's no negative signals in the few hundred patients thus far reported on Actemra. She's told by me to go ahead and get pregnant, and if she does, I'll report it to the company and blah, blah, blah. But she's not pregnant now, so don't write me up. And then if she does get pregnant, she could actually stop the drug because her past pregnancies, she did very, very well during the pregnancy off of biologic therapy. She may well repeat that. You know, not all RA patients do fabulous when they get pregnant. So that's the plan. Again, I would have told her the same thing had she been on, let me think about this. Tocilizumab, yes. Any TNF inhibitor, yes. Abatacept, yes. Rituximab, yes, a long half-life, so you know I don't want them to get pregnant when they just got the infusion, but that's probably okay. There's not enough known about the JAK inhibitors yet thus far. It doesn't seem like there's a negative signal there. There's been actually a publication on this, so I think a little more time. Again, they call whenever I'm recording. This is interesting. But forget about Xeljanz right now would be my suggestion, and maybe ask me next year or ask the other mavens in pregnancy about what they think about using tofacitinib or even baricitinib in women who want to get pregnant. So that's today's lesson. Tune in for more lessons from the clinic. See ya.